Okay, I think we're live. Hope everybody is doing well. It's the 6th of August, the Thursday. I almost combed my hair today. Uh, and it's doing well. And okay, going live again. It's interesting. Facebook, I've mentioned this before, does make changes. It makes something that works really easy, sometimes very difficult, but I think I'm okay. Anyway, this talk is on screening CT. It's interesting that screening is something radiology has always done. Way back when we did barometers for screening for colon cancer. We've done mammography for generations, it seems, looking for early breast cancer. There was screening done with chest x-rays to look for early detection of lung cancer in smokers. That never really panned out. And of course, then CT came along and that has panned out very nicely. So really, screening is this balance between can we improve the early detection of disease, particularly cancer, but also other things like cardiac disease, and can we make a difference? So one of the simplest things we do, cheap, easy, and amazingly good, is calcium scoring. It's a quick couple second scan. You measure in Angus's units the presence of calcification in the coronary arteries. 0 is your best score. And then patients are managed based on their score, and they're managed very successfully. It's better than any of the risk factors that were ever developed. It's easy to use, and people are getting them more frequently, patients age 40 or 50, as a way of monitoring their cardiac health, determining whether they should be put on any medications or not. So it's really a very strong routine study that I'm sure all of you are doing in practice. The second thing is lung cancer screening. Lung cancer screening was argued about with CT, I think in part because of the bad experience with x-rays. But lung cancer screening now, the only argument has changed is when do you start? 30 years of smoking, now it's 20. Age 50, age 60, when do you start? Should it be for all people or just for smokers? Most of the time it's for smokers. And you can pick up cancer when it's early, when it's a nodule, and then be able to resect it and cure the patient, rather than waiting for stage 3 or stage 4 disease. Virtual colonoscopy is another. Perry Pickering wrote a lot of articles about that. It's not popular in the radiology community. It's a good screening tool, but the problem is it takes a long time and everyone's busy. The techs don't like to do it. The doctors don't like to read it. And it's reimbursed very poorly. So it's available. It's there. We do a couple a week. We would all be happy to do none of them, unfortunately. With colon cancer screening, colonoscopy is the gold standard, of course, but even colonoscopy misses 10 to 20% of lesions, and so AI is being used to assist in colonoscopy. Also, companies like Exact Sciences and other companies like Grail, and there's some other companies I'm leaving out, have these really good tests where you can do either stool or now blood to look for early colon cancer. So screening is big. I think that what you'll see in the future is these liquid biopsy type screenings, basically getting blood, looking for many diseases, including early colon polyps. And there is a lot of good work being done in that regard. People also talk about screening, looking at bones, predicting osteoporosis, intervening before patients get fractures. That's a really good thing to do, and it's becoming more common. We also talk about screening for pancreatic cancer. For patients at high risk, CT or MR can be done to look for the detection of tumor or cysts, so you can manage patients more aggressively. Again, it's been done. The results are okay, but you need to scan a lot of patients to find the cancer. And it's not an easy screening. AI hopefully will be able to improve detection, Things like radiomics improve detection, and then the screening will be used, but in a higher risk population. I don't see it for a long time to be for everybody. We talk about other screening. So I mentioned pancreas. People talk about vascular screening with ultrasound, CT or MR, looking at thoracic aorta, looking at abdominal aorta, presence of aneurysm, size of individual chambers, are all things that can easily be done, can be done in the screening mode. What people would like to do is kind of, remember we do the whole body screening from the maybe the neck, not the whole head, but you can do the head down through the pelvis, looking at plaque burden, looking at changes that predict disease, whether it's in liver, whether it's in kidneys, incidental renal cancers, adrenal lesions, including things like pheochromocytomas, liver disease. There are many things we could do. The real challenge is how can we do them efficiently so that we don't overcall or undercall. When whole body screening was done with CT, the challenge was that people would read 80% of the patients abnormal. It incurred a lot of cost because of the follow-up exams, a lot of stress, unnecessary biopsies, unnecessary procedures. So with screening, what you have to do is have a very high positive detection rate and a very low false positive rate. You can't be ordering more studies or doing more things. That's what basically ruined whole body screening. People now, there's a number of companies that will mention them do whole body MR. The challenge, of course, is they're doing one sequence top to bottom, a lot of false positive, false negatives, not really ready for prime time. A good article, I think, by Davenport from Michigan showed how bad the process is with the false positives and all the things that come from that. So let me end here and say screening, when used correctly, is great. Bone mineralization, lung cancer screening in smokers, coronary artery calcification for all of us, pancreatic cancer screening, probably with MR over CT for patients at higher risk, and aorta screening, maybe with ultrasound, MR, or CT. Again, the goal is early detection of disease when something can be done. If you ask me the future, the integration of liquid biopsy, things like Exact Science, things, like that, merged with imaging techniques are really the way to go. And I think you're going to see this really pick up steam over the next couple of years. And with that, have a great day, everybody.